everyone, Salamastian. I'm Nakamura from Kagoshima University, Japan. Today I will talk about LUFO-1 surgery for orthognatic treatment. LUFO-1 surgery is one of the representative techniques for maxillary advancement in orthognatic surgery. If this is successfully implemented, there will be a significant benefit to the patient, but it often has complications, so it is necessary to master the correct techniques for osteotomy. Orthognatic surgery corrects skeletal deformities and adjusts the relationship between the upper and lower jaw. The surgery can improve appearance, mastication, speech, and breathing function. Jaw deformities requiring orthognatic surgery are not urgent, such as malignant tumors. Therefore, it is important that the patient be well prepared for surgery and the surgery proceed without complications. The benefit of LUFO-1 surgeries are improvement of mid-facial concavity and natural facial appearance, obtain post-operative occlusion stability while reducing the distance of mandibular advancement. The horizontal inclinations of the occlusal plane can be improved. LUFO-1 surgery is often performed for the patient with remarkable skeletal mandibular prognatives combined with maxillary protrusion. In such a case, two-jaw surgery consisted of maxillary advancement by LUFO-1 surgery and mandibular setback surgery such as SSRO, sagittal split ramus osteotomy, and IVRO, intraoral vertical ramus osteotomy is carried out. So the indications for LUFO-1 surgeries are follows: maxillary protrusion, mandibular prognatives with midfacial depression, horizontal inclinations of the occlusal plane as shown in the slide, maxillary asymmetry, vertical overgrowth such as long face and open bite. So however, compared to the mandibular surgery, maxillary surgery is more complicated and has more complications that requires attention. Complications of LUFO-1 surgery include significant bleeding from the maxillary artery. Some reports of thousands of milliliters of blood loss have been seen. Undesirable relapse of the maxilla, hypernasal voice in patients with cleft lip and palate, rarely necrosis of the maxillary bone, nerve damage, and infection of the bone-fixing materials. This slide shows a significant simple flow of orthognatic surgery. Patient visits the hospital with a chief complaint of malocclusion and or facial deformities. First, surgical treatment is made in the joint conference with the surgeons and orthodontists. Step 2, preoperative orthodontic treatment to align the occlusal plane is performed for 1 and 2 years. And step 3, patient undergoes orthognatic surgery to improve the occlusion. And step 4, postoperative orthodontic treatment is necessary for 1 to 1.5 years for finalize the occlusion. For diagnosis and surgical planning in the conference with surgeons and orthodontists, we mainly use the cephalograms and CAS model. In this case, the relationship of the upper and lower jaws are good, but horizontally, the occlusal plane is inclined. So the diagnosis was angle class 1 malocclusion with horizontal inclination of the occlusal plane. We planned the root for 1 osteotomy with 3 mm upward advancement on the left side and SSRO with 1.5 mm setback of the mandible. Before surgery, head and soft tissue simulation is very useful. CT image can be used to analyze the bone form and to simulate the hard tissue movement by surgery. Soft tissue simulation is also a benefit to create a predicted facial appearance. So you can see the predicted appearance with a natural facial profile. This is also allows the patient to undergo the surgery with confidence. Thank you for your attention. Terima kasih.